On behalf of the University of Washington School of Medicine, my co-moderator, Dr. Mengert, and myself, we're very excited to welcome you all to Mini Medical School 2006. In this brief overview that I'll provide you, I'll touch on the who, the what, and the why. The who is who are these two moderators that are charged with making this engaging, interactive, and entertaining. What is this medical school that you're attending? And why? Why are you here? What should you expect to get out of this? And what do we expect to get out of this? First, the who. Who is Terry Mengert? That's Terry Mengert. Dr. Mengert is about as UW as it gets. He has 2 undergraduate degrees from the University of Washington. He's got a medical degree from the University of Washington. He did his residency at the University of Washington, and he's been a faculty at the University of Washington for 19 years. He's a professor of medicine. Dr. Mengert is arguably the best teacher in the School of Medicine. He's very humble, and since I get to speak first, I can embarrass him. He got an award in 1998 that actually attributed that fact to him as the best teacher in the School of Medicine. He actually has more teaching awards than I can list on the slide, but a couple of the ones I thought were significant. The first is the Beeson Award that stated he was the best teacher in the Department of Medicine, and the second was that he was named as a role model by fourth-year medical students. And I think you'd agree that looks like a role model. Don't you think? And I think it's very important when we think about education that so much of it is done by modeling. And to be named a role model really means that Terry is the type of physician that students aspire to be. And I think one of the reasons that occurs is really his teaching philosophy. He advocates learning by doing, and he uses an analogy to tennis playing. And to quote, "A tennis player does not get good by reading or hearing about how to hit a backhand. You get good by doing it. The same is true of learning to be a doctor. He asks a lot of questions, and he expects answers." So here's Terry not getting an answer. And so one of the things that we hope that this will be an interactive experience, because we really want you all to take a lot from this and get a better understanding of who we are and what our commitments are at the University of Washington. Now, as opposed to Terry, who did most of his training here on the West Coast, I've actually done most of my training on the East Coast. I got a degree in health sciences from Johns Hopkins, did a residency in radiology, and then 2 fellowships, one in neuroradiology and one in neurointerventional radiology. And really what my focus has been is to treat patients with stroke, because I think stroke affects the essence of the person. And if you can minimize the damage a stroke has, I think you've had an impact. It's also affected my decision to get involved with administration, which is to try to create an environment where a group of people seek to have an impact. So I was previously vice chair and interim chair at Hopkins, but was very excited to be offered the chairmanship here in 2002. And the thing that brought me here was I really think UW Medicine is unique in terms of a place where you can make a difference. And that really is one of the things that we want to work with you all, to work together, community, medical system, to have an impact. And when I think about what I find important in trying to motivate students, it's to convey to the students that they can and they should make a difference, that it's really an obligation, and that my job as a teacher is to help provide the tools that they need to have that impact. Now, when I think about sharing a podium with Dr. Mengert, given all of his teaching awards, I'm reminded of W.C. Fields, who says, never share the stage with animals or children, and one might add, or Mengerts, because they're very gifted people. So I accept that my role here will really be is Terry's helpful sidekick. And again, we look forward to trying to create an interactive and an educational experience for you all where we really work together. So what is UW Medicine? Well, this was UW Medicine in 1939. And if you look closely, it was a big golf course, which is really quite striking because if you look at the leading medical schools in the United States, the top one or two, they've all been around for 100 years plus. But what's striking here is we've quickly gone in 60 plus years to being one of the top 1 or 2 medical schools in the country. And I think the reason that we've done that is that we've been agile and we've applied resources to things that will have the greatest impact on our patients in science. And I think the best demonstration of that, and let me show you where we are today, is this is now the medical system. And it's a huge medical facility with both a hospital and a number of science institutions. But perhaps most emblematic of how we got where we got, because I think you'll be surprised to hear that although we're the #1 funded research institution in the country, that's a public institution, and we'll hear more about that, we're actually 49th in terms of state support. So we do it really by being agile and learning how to use limited resources to have an impact. And this new arrow that I just put in the bottom corner here, that's actually demonstrative, I think, of some of the reason why we're successful. And that's going to be where the new Faggy building comes up. And what is that? That leverages genomics. It's going to bring together our Department of Genomics. And as you know, the genomic revolution is defining what are the diseases that we're at risk for and helping us be positioned to treat them with our bioengineering department, which is the #1 bioengineering department in the country. And by bringing them together, we'll be positioned to develop the tools that will help us treat the diseases of tomorrow. So I think that that's a very nice definition. Now, when you think about that campus, that's not really all that represents UW Medicine. And perhaps as big a component are the hospitals that we consist of. And so what are those hospital organizations? It's Harborview Medical Center, it's the University of Washington Medical Center, it's the University of Washington Neighborhood Clinics, and then it's the physicians that work at those hospitals as well as Children's Hospital. Our closely affiliated hospitals are the VA, the Children's Hospital, and the Hutchinson Cancer Research Center. And together we formed a membership organization, or another organization, if you will, called the Seattle Cancer Care Alliance. So you can see the breadth of UW Medicine is really quite substantial. What unifies all of those different organizations? I think it's a clearly defined mission statement. And this is our mission statement. Our mission is to improve the health of the public by advancing medical knowledge, by providing outstanding primary and specialty medical care to the citizens of the region, and preparing tomorrow's physicians, scientists, and other health professionals. I talked about us being one of the top 1 or 2 medical schools in the country, and I was actually a little bit surprised, because when I was back on the East Coast, everybody knew that the University of Washington was one of the leading medical schools in the country. And then when I showed up here in Seattle, folks really didn't know it as well. And so I think it is important for us, again, to work together, to have an impact. And I think, again, it helps by understanding where we're positioned to make things better. So what are some of the metrics? Well, it turns out we've been ranked #1 in primary care for 12 years, #1 in family medicine, and #1 in rural health teaching. Across UW, 250 of our physicians are listed as the best doctors in America. UW Medical Center has been the #9 medical center in the country, and Harborview has been identified as the leading trauma center in the country. And the spectrum across which we've been delineated as leading areas of medical specialty goes from cancer to ears, nose, and throat, geriatrics, gynecology, orthopedics, rehab, rheumatology, urology. So really a very broad spectrum of areas where we have leadership and can have an impact in the community. Some of the areas of innovation and leadership, renal dialysis, where was that discovered and implemented? Here at the University of Washington. Bone marrow transplant, medical ultrasound, hepatitis vaccines, computational biology. Under regional and safety net care, we'll hear more about that from our speakers today. And in terms of basic science advances, transgenic animal technology, cell replication, reversible protein phosphorylation, molecular genetics, all the things you see listed, which are helping us get a fundamental understanding of disease at a basic science level and positioning us to better fight the diseases that affect us all. Notably, outstanding faculty, 5 Nobel laureates, 26 members of the Institute of Medicine, and 26 members of the National Academy of Science, which is fairly substantial. So what are our goals before I introduce our speakers? The first is to educate you in an interactive way about the biomedical sciences, from basic research to patient care. And here's our first opportunity for interaction that's not, as Dr. Robinson suggested, a sleeping audience member, but something that Dr. Mengert is going to use to show us about emergency medicine today. We also want to help you develop a better understanding of what a medical school does and the resources it has to offer the community. We want to create a partnership with you in the appreciation of the sciences here at UW. And I'd like to emphasize the last, which is to have fun. I think life is short, and I think that you should enjoy the opportunities to learn and work together. So we also really hope to introduce that into our time together over the next 6 weeks. But tonight, again, we're going to learn about some of the things that happen in emergency care. We're also going to hear about UW medicine in terms of, as you all know right now, the burden on society is huge in terms of unemployment, people not having enough money to pay for health care, rising health care costs. How are we going to meet the needs of society? Well, it actually is a big concern for us. So we talk about some of the challenges and the way that we confront those. And this is the timeline. And again, tonight we'll hear first from Dr. Larry Robinson, second from Dr. Mengert, and in the second hour we'll hear from Scott Barnhart. Now, you've already heard about Dr. Mengert. Let me briefly introduce Larry Robinson. Larry went to Brandeis University and got a degree in chemistry. He went to the Baylor College of Medicine and did a residency in physical medicine and rehabilitation at Northwestern University. In 2000, he was accepting of the position of chair of Rehabilitation Medicine, and it's one of the leading rehab med programs in the country. Because he didn't have enough to do, in 2005, he accepted the role of Vice Dean for Clinical Affairs for all of UW Medicine, which is an enormous job. He got the Outstanding Teaching Award in 1992 and 1995, and actually got a Distinguished Research Award in 2005. So he's what you call a quadruple threat. He's a great clinician, great teacher, great researcher, great administrator, and has over 120 publications. I'm not just saying that because he's my boss. The other thing about Larry, if you look closely, is this is Larry in his car. And if you look closely, you'll see a fin on the back of his car. And this showed up in the PI on Friday. And I guess that's called autobiography. And so you're supposed to name your car. Any thoughts on what Larry named his car, given the fin? He called it Wanda. Fish called Wanda. So one of the, and that's why we love Larry, is that, you know, despite his accomplishments, what brought me to the University of Washington was the opportunities. What keeps me here is the people. And Larry is a very nice person, one that's good to have at our helm. So with that, I will introduce Dr. Robinson.
So I wanted to talk today a little bit about the mission of the Academic Medical Center and to build upon what Dr. Beauchamp has introduced. So there are really three kinds of core elements to the Academic Medical Center, or AMC. And we think of it as a three-legged stool. You need all three legs to be strong. Of course, if you were missing one or two legs, you would have a loose stool, which would be a problem. The three legs are teaching, research, and clinical care. All three of these need to be strong to have a strong academic medical center. So I wanted to talk about some of the elements, some of the things that you wanted to know about the three elements of the mission. And the three elements are, what's the importance to the community? How are these three different areas interrelated? And how are they funded? The teaching mission is one that we take very seriously, and which I believe we're very strong at. UW is the only medical school in the WWAMI region. And WWAMI means Washington, Wyoming, Alaska, Montana, and Idaho. So we provide the only training site for medical students, as well as some other health professionals in this 5-state area. And what you see on the map to the right is some of the training sites which can be at the medical student or resident level. Why is the WWAMI teaching important? Well, if you look at this slide, you'll see the number of physicians per 10,000 population in the United States. The black line is the average in the United States, and you can see on average there's about 22 physicians per 10,000 population. Now, some places like New England have more, and they're more like 30 physicians per 10,000 population. But look at the red states. The top red one is the state of Washington, and that's really about the average. But then look down at Montana. It's less per population. And as you get down to Alaska, Wyoming, and Idaho, we have a relative poor representation of physicians per population compared to other states in the United States. So the training is a key mission of the University of Washington. How is the medical student teaching funded? Well, there's a few sources. So one is tuition. Tuition for UW Medicine, as for other parts of graduate and undergraduate tuition, does not even nearly cover the cost of education. Endowments have been useful, and we're in the middle of a development campaign now. What the endowments have done have allowed us to start new teaching programs, such as the college faculty and other innovative teaching programs. But again, they don't cover even a significant part of the total cost of education. As Dr. Beauchamp mentioned, state funding is one element of funding, but that's relatively low. If you look at the whole of UW Medicine and where do the salary dollars come from, less than 5% come from the state of Washington. Most of it come from other sources. And also, as Noah mentioned, we're 49th in comparison to other medical schools for state funding. Training grants provide a little money for funding, but these are harder to get and relatively few in number. And then clinical revenue, that is the revenue generated from seeing patients and providing clinical care, generates a significant amount of the funding for medical education. Now, teaching is dependent upon the clinical and research missions. Now, why is that? Well, first, the clinical mission, you can't teach people how to be physicians without clinical exposure. It's just as in Dr. Mengert's philosophy, you can't teach people how to play tennis just by a lecture and reading books. It's the same thing with teaching people how to do medicine. You really need to provide them the clinical exposure. It's also dependent upon the research mission. We need research in order to teach tomorrow's researchers and thus improve health care for the citizens of the state of Washington, the United States. Also, we need our trainees in clinical disciplines to understand research, because they're going to be reading the research and applying it, and they have to know how to interpret it appropriately. And also, hopefully, they'll be doing the research for some cases. Well, why is research important to the Academic Medical Center? First and foremost, we want to discover new and better ways to make diagnoses and to treat and prevent illnesses for our citizens. Research also contributes to training, and it contributes to the economy of the region. We bring in over $600 million in external funding for research, and that makes a big difference on the region's economy. As I said, 2005, we brought in over $600 million in external funding, and this can be from National Institutes of Health, from Department of Education, from a variety of other sources as well. We are number 2 in the United States for medical school funding, second only to Harvard. Now, what's interesting is, although we get all this funding, it provides the direct costs for research, but it doesn't really provide for all the indirect costs for research. So it's estimated that for funded research, there needs to be a cross-subsidy of about 10 cents per dollar to cover the indirect costs, and that's things like space, administration, utilities, et cetera. Also, the problem is that even though all these research funds come in, you can't use those funds to cross-subsidize teaching or clinical care. So the NIH, when they give us a research grant, we have to use that money for research. We can't use it to cover someone's time to do some teaching or to cover someone's time to provide care. Now, the research is dependent upon the other 2 parts of the mission as well. It's dependent upon teaching, and it's dependent on teaching because that is how we will attract the best faculty. Faculty want to come to the university not just to do research, but to be active teachers. And the trainees also provide the manpower for much of the research. And so as we get graduate students, they provide a lot of the manpower in the laboratories to run research grants. Research is also dependent upon clinical care. So where do the ideas come for new research investigations? Well, they really come from clinicians, people who do clinical care and discover this is a problem that needs to be solved. They apply for a grant, they develop the techniques to study their hypothesis, and that's really how research is advanced. Also, clinical research will need access to research subjects. So if there's a study of a clinical trial of a new drug or a procedure, we need clinical subjects to participate in that research. Now, clinical services of the AMC are important for providing access to the most complex medical services, which are generally offered only at an academic center. They're important for providing specialty care, and they're important for providing a way to apply the latest research in medicine to patient care. So these 3 missions, the research, teaching, and clinical care, are all linked at that individual faculty member level. And if we can't keep the clinical mission strong, which is what we're going to be talking more about tonight, we'll lose our strength in research and teaching. These are all very closely linked one to the other. So what does this mean at the patient level, someone coming into the hospital or into the emergency room? Well, since I'm chair of rehabilitation medicine, I'm thinking about a patient who might sustain a traumatic brain injury in a car accident, which happens not too uncommonly. What does the research mean to that person? That means that that person would undergo some treatments that would be relatively new and not available in the community. For instance, they might have treatment with magnesium sulfate, which shows promise for minimizing the effects of a traumatic brain injury. They would be enrolled in the traumatic brain injury system of care, model system of care, which is sponsored by the Department of Education, and be exposed to some of the latest treatment techniques. They might be exposed to one of our treatments for depression. We're doing a couple of studies, one on a medication and one actually on exercise to treat patients with depression after traumatic brain injury. And what's interesting is it looks like exercise might be just as effective as a antidepressant medication. We're also doing a study on telephone follow-up. Many patients with a brain injury, they come to the hospital, they're discharged, and they can be lost to follow-up, and we don't hear from them. And what it looks like is that if you do a nursing call about a month after their discharge, ask how you're doing, what are your problems, that you can really improve the outcome after the brain injury. Well, what impact does teaching have on the patient with a brain injury? Well, they would be exposed to residents and students. And by being exposed to those trainees, you really get more people involved in the person's care, and you can provide more constant care throughout the day. They're also discussed at case conferences, so you discuss the difficult cases and ask people's opinions, and you generally get better care if your case is discussed amongst several people. You're exposed to the latest research. We all have to keep on our toes to keep ahead of our trainees. And the teaching also provides an additional way for us to treat the underserved. Well, how are clinical services funded? Well, our clinical services are funded through private and public insurance. Now, one thing is that the payment levels vary substantially, and so there are some insurance companies that pay very well, and then some state programs that don't cover the cost of care. And so inherent in the system is a subsidy to cover the cost of care for the underinsured or uninsured. So in other words, the commercial payers who pay a high rate, those dollars really go to cross-subsidize the less insured or uninsured patients. And just by the virtue of the way the medical system is set up, teaching hospitals such as ours represent 29% of the nation's total hospital beds, but deliver about 80% of the total charity care. This is more of a problem now than it was 30, 40 years ago. So what this slide shows, this shows the situation in 1970 and 2005 for two different options of Blue Cross coverage. And it's displayed as a percentage of the minimum wage. So on the left in 1970, I lost my pointer. There it is. It took about 15% roughly of the minimum wage to buy health insurance. In 2005, it takes about 100% of a minimum wage to buy health insurance. So what that means is that there are more and more underinsured people out in the community, which creates more and more of a problem for society and for the academic medical centers, which often see the majority of these patients. One other fact I wanted to show you was the influence, the interaction between how many people are insured and what's the affordability index of insurance. And so the affordability index is the per capita health spending divided by personal income. So roughly what percentage of average income goes towards health care. And as you get to, we're right about here right now, 15% of our average income goes towards health care, and you can see we have about 75% insured. As you get to greater and greater proportions of dollars required to go to health care insurance, then the proportion of insured goes down. And it would be really nice if we were down at a place where over 80 or 90% of people could be insured. So the academic medical center does have a balance to work on. We want to serve the safety net population, those people who are underinsured and uninsured, but at the same time we need to preserve the other parts of our academic mission, such as teaching and research. So the conclusions I wanted to leave you with are that the academic missions of teaching, research, and clinical service are vital to our community and our region. And these three missions are inextricably linked. And so we really want to maintain that whole academic stool with the three legs that are strong so we can best serve our community. Okay, thank you for your attention.
So this is our interactive friend, Dr. Mengert.
Hey, good evening, everybody. It's a pleasure to be here with you all again. Norm, I really want to thank you for that nice introduction. I don't think I deserve it, but I like it. I like listening to it anyway. Hey, Sir William Osler, who's a role model for many of us in healthcare, said that to prevent disease, to relieve suffering, and to heal the sick, this is our work. This is what we're about as physicians. And underlying all of that is the idea of service. Tonight, I'm not going to read a poem, but I will introduce every session after tonight with a brief poem. And my idea behind that is, unlike prose, poetry does not explain things. It conveys the feeling of what happens. It articulates our deepest wanderings and aspirations. And in the medical literature, the poetry written by physicians and nurses is absolutely outstanding. It places you in the position of being a healthcare provider. And I'll keep them brief. I won't make them too long. They're not my poems. But that's how we'll introduce a session from here on out. So when I start with a poem, you won't say, oh, what is he doing? Well, hopefully, you might still say that, but hopefully you understand where I'm coming from. My objectives over the next 20 minutes or so is to briefly outline the healthcare crisis. Now, Dr. Robinson has covered that so nicely. I'm not going to spend much time on that. And I want to make all of you miniature emergency medicine providers, because emergencies happen everywhere, and you're seeing a lot of this on the television as well. And the specialty of emergency medicine is one of the leading specialties in providing care to the non-insured or underinsured in our country. And as part of that, I'm going to go over the concept of triage, which is nothing more than prioritization of care, and outline the approach to a patient, and then briefly go over the new guidelines for CPR, because my own philosophy is that every evening when you come here and walk away, you should be better healthcare providers yourself, even as lay practitioners because healthcare is so critical. Ours is a crisis in healthcare. There's no question about it. And I think experts in the area have best summarized it as American medicine is a paradox of excess and deprivation. We have the very best that Western civilization has to offer, and some of the very worst as well. Whenever you watched that tragedy that occurred in the American South with Katrina, I think everyone was witness to an element of American society that isn't getting its needs met as a population. 45 million Americans are underinsured or not insured at all, and 83% of those are working people. So 83% of those are working people. They just can't afford insurance. 8 million of them are kids. There are huge socioeconomic disparities in American health care. There's lack of access to health care, so that, for example, 5,000 Americans die every year of asthma in our country. Asthma is a completely reversible condition. It's complete reversible airway obstruction. And yet 5,000 Americans are dying, and you say, who are those people? They're inner city people. They're people with declining health of our cities. They're minority patients who can't get access to the care and can't get the kind of health care that America knows how to provide, but for some reason doesn't still provide. And then there are quality of care issues where even if you get into a good place, the Institute of Medicine estimates that as many as 50,000 to 100,000 Americans are dying every year across our country because of errors made in their health care. So we've got a crisis. And part of my role here and part of Norm's role and all of our gifted speakers is to make Americans aware of the crisis, because it's our problem as a people. I love books, you guys. I love books, and sometimes books pick me. Have you ever had that experience? You're walking through a bookstore, you're walking along the aisles, and all of a sudden the book talks to you, and you pick it up. And this is a book by an American Buddhist nun, a Canadian actually, When Things Fall Apart. And I was just paging through it, and she was talking about the charnel grounds in Tibet. And I just opened the book to this page. And she said, perhaps the closest thing to a charnel ground in our world isn't a graveyard. It's a hospital emergency room. It smells, it bleeds, it's full of unpredictability, but at the same time, it's self-radiant wisdom. It's good food. It's that which nourishes us, that which is beneficial and pure. So I got into emergency medicine as an outsider. My training was actually internal medicine, but I loved emergency medicine the most in my training. And Dr. Kopis at Harborview, as the director of that emergency department, had a very powerful influence on me. In my training, there was no attending who spoke more directly to myself as a person and my being as a potential doctor than Dr. Kopis did. And a job opened up in our emergency department, and I gravitated to it. So when I think about emergency medicine, I think of it as someone who came in from the outside, much like an immigrant might come to America and know a lot about America that we who grew up in America never took the time to learn about. Albert Schweitzer, outside of his hospital in Africa, had a little sign. It was a plaque, actually, and it said, no matter who you are, no matter what time you come, no matter what your problem, in this place you will receive care and compassion. And if you thought about it as an ideal, that's what emergency medicine should represent to Americans. No matter who you are, whether you can pay or not. As a matter of fact, it's the only specialty that is mandated by federal law to see and evaluate and stabilize a patient whenever they show up, not on the basis of whether they can pay for their care or not. That's what emergency medicine means to me. So if you thought about what emergency medicine is, it isn't acute care necessarily. One of my favorite stories is from Ina Yoloff, an author who wrote the book Hospital, and she interviewed practitioners throughout the New York area. And one of her stories was from a nurse who worked in the emergency department at Columbia Presbyterian, and it was 2 in the morning and a man showed up with abdominal pain. And the triage nurse said, "Sir, how long have you had abdominal pain?" And he said, "I've had it since 1953. And she said, "I wasn't even born yet in 1953. What makes you come in tonight at 2 in the morning?" And he said, I just couldn't take it any longer. So it's not necessarily acute care. It's just care practiced in a place where people can show up. They show up because they're worried about it. They show up because they hurt. They show up because they can't sleep that night. They show up because they can't handle the discomfort anymore. It's often chronic problems as well as acute problems. The concept of triage is from the French verb trier, which means to sort or to place into groups. And it dates back to the Napoleonic Wars, where soldiers injured in the field, they had to decide who to take care of, who could they best support that army in fighting a battle. So they'd put people into groups. And we use it in modern emergency care just to say we're going to place people into different categories, not in terms of do they deserve care, but in terms of prioritizing their care. And we use 5 categories. So category number 1 is a person who's comatose, or not breathing, or has active CPR going on, or has had an endotracheal tube placed in the field by the paramedics. A category 2 patient is a patient who's got a very worrisome chief complaint. Their chest is hurting. They can't breathe. They're in severe pain, or their vital signs are terribly abnormal. A category 3 patient is a stable patient, but they're going to take a lot of time to evaluate. That's a young woman who's vaginally bleeding. Could be pregnant, could be a complication of pregnancy. That's any of us if we present with abdominal pain, assuming our vital signs are okay. A category 4 patient is just going to use one system. They're a stable patient and they're going to use one system, like we might need to get an x-ray. So that's an ankle injury. And a category 5 patient is a patient who's got a simple problem like an earache we don't need to do blood work on. We can just do an evaluation, look in their ear, see if it's infected, and take care of them. So that's the idea behind triage. I always thought it would be fun to have a dog named Triage, because in my place of practice, you constantly hear the loudspeaker over the emergency department go, triage, triage, and that means somebody's presenting out front who needs to be evaluated in terms of placing their categorization of care. But let's see how good you are, all right? So you're working in the emergency department at the University of Washington. What the heck? You've got a free evening. We can use the help. And things are very busy. 5 patients are checking into the emergency department even as we speak. And the attending asks you to triage the patient, to quickly evaluate them and prioritize their care needs. So one patient is a 26-year-old college student who injured his or her ankle playing basketball at the IME building. The ankle's painful, it's swollen, but that's it. Another patient's a 48-year-old male who arrives via Seattle Medic 1 complaining of chest pain. The third patient is a 30-year-old injection drug user who is frankly comatose, brought in by, quote, friends. Maybe it's a drug overdose. They are completely unresponsive. The next one is a 70-year-old who's having a hard time speaking and understanding language and has a right facial droop. This side of their face is like it's pouring downward. And the last one is a 16-year-old woman with abdominal pain, nausea, and vomiting. So in that list of things, who's our number 1 priority patient? Everybody all right? It's the heroin addict. It's the comatose patient. And then our next category of patients, there are 2 of them. Who are those 2? Okay, good. So the person who might be having a stroke and the chest pain from Medic 1. The category 3 patient is which patient? The 16-year-old. And the person who brings up the rear? The ankle injury. Good. That's great. That's how this business is done. This is how triaging is done, is making a quick assessment on the basis of the chief complaint and their vital signs. Now in healthcare, traditionally, the way we teach our students is a very thorough way of approaching them. And it's the way you're used to seeing a healthcare provider in the office, maybe, or if you've ever been admitted to the hospital without a life-threatening problem, is they do a good history. They do a physical exam. They maybe do some laboratory tests, an x-ray or 2. They decide on a list of possibilities and what you could have, what their working diagnosis is, and then what their what other things they need to check in or check off on the list of diagnoses. And this is a wonderful way to take care of people because it's comprehensive. But it assumes something. What does it assume? time. It assumes that we have the time to do all of that. And time matters in emergencies, and we don't have all the time that we want. In major trauma, as is done so beautifully at Harborview Medical Center, there's the concept of the golden hour. Within 1 hour of that patient's arrival, everything emergently that needs to be done, including involvement of all needed consultant services, all needed imaging, all needed laboratories, all needed emergency procedures, are done and taken care of within that first hour. And I remember once when I was in training at Harborview, we had a man come in with a ruptured abdominal aortic aneurysm. And from his arrival to him being whisked off to the operating room was 8 minutes. And in that time, everything was done. 2 IVs, intubated, chest x-ray, EKG, type and cross, vascular surgery consult, bedside ultrasound, everything done. And it gives me goosebumps to talk about it because it's so magical. So time matters. In acute MI, we've got to get that blood vessel opened as soon as possible. In the setting of stroke, we have a 3-hour window in which we can open up an occluded blood vessel causing a stroke in a patient if we're giving peripherally administered clot-busting drugs. We have a 3-hour window from the start of symptoms to when we need to start that drug. And with Norm's able assistance, we expand that window to 6 hours, but we need someone with expertise in that area to take him to the angiography suite. In bacterial meningitis, antibiotics started in 30 minutes. So what it comes down to is in a crisis, we borrow from the trauma surgeons. The trauma surgeons were the great guides in teaching all of us how to handle a setting of an emergency. And they're A, B, C, D, E. I don't know what they do in Czechoslovakia, but it works great for English-speaking peoples. A, airway, C-spine stabilization. B, breathing and ventilation. C, circulation and hemorrhage control. We get access to them with IV access. And if they're bleeding externally, we put pressure on it, as well as hanging maybe some fluids. Disability in the DON'T regimen. Disability or the brain, we do a quick neurological exam. And DON'T stands for dextrose, sugar. We have a lot of diabetics out there. Their blood glucose drops, gets too low, they have altered mental status. We check a finger stick glucose, and we get that sugar back into the normal range. Oxygen. We want oxygen on people, and we want their oxygen saturation to be beautiful. N stands for naloxone. That's the antagonist for opioids. So if I have a heroin overdose come in, I can reverse the terrible effects of heroin on that person's airway and breathing by giving them a little bit of naloxone. And T is thiamine, which helps with a type of encephalopathy, a brain dysfunction that alcoholics can get. Only after we've done that primary survey, forced ourselves. See, what you do is you're standing at the bedside and you have this terrible feeling in your gut that this situation is in a crisis mode and we don't want it to be like that, and you want to get it all fixed in a hurry, but sometimes you can't. You have the discipline to hold that pain inside of you as a caregiver, and you go through the steps. Am I happy with their airway? No. Well, I need to do what I need to do to get that airway. Am I worried about their spine? Yes. Well, then I need to immobilize it. How's their breathing? It's not good. Well, then I need to breathe for them. How's their circulation? You got the idea? It's a discipline at the bedside. And only after that do they then get the secondary survey, which is the head-to-toe approach. I like to think of erecting 3 pillars around somebody who's in trouble. One is what we in the emergency department call the safety net, which is getting oxygen on them, IV access, hooking them to a cardiac monitor, and hooking them to a pulse oximetry monitor. And it's not 4 separate things. It's one thing. And I'm always reminded in training with Dr. Kopis, he used to say the quality of an emergency department can be measured by the speed with which the staff puts oxygen on the patient. Dr. Kopis was so good for these pithy teaching statements. Another one of his was, hypothesize the worst, then prove it isn't so. And one I never liked very much was, Mengert, what the hell are you thinking? But I learned to live with that one, and that's how we learn. And he was always good about keeping me in line. Then vital signs is another pillar, the basic 4, pulse, blood pressure, respiratory rate, and temperature. but some other ones. If I have a patient with chest pain, another, quote, vital sign is getting an electrocardiogram on them. If I have a patient with altered mental status, it's checking that finger stick glucose. If I have a pregnant woman, it's checking their fetal heart tones. And drilling in this so much that it's a reflex. And then the primary survey, like we talked about. When we're worried about somebody bleeding or having a volume problem, we hang fluids on them. And the fluids that we hang are balanced salt solutions because they're cheap and they're readily available. Normal saline or lactated ringer solution. And I've already talked about disability in the DON'T regimen. What's the D stand for? Dextrose. O, N, naloxone, the opioid antagonist, and T is thiamine. And in your handout, there's a little we talk a lot in medicine about differential diagnosis, and it's the list of possibilities. So our medical students on rounds in the morning, their teaching resident may turn to them, if I were a student, and they may ask me, they say, Terry, give me a differential diagnosis for the causes of altered mental status. And I hopefully would come up with a list of things. And in my teaching, I tend to use mnemonics a lot. A lot of people don't like mnemonics. And I have to tell you, when I was asked that as a student, I could remember the mnemonic, but I couldn't remember what it stood for. So they asked me, and I said, TIPS vowels. And they said, oh, that's good. What's it stand for? I have no idea. But it does stand for things. So if you can take it to the next step, that works out well. Healthcare is a crisis. Emergency departments are part of that safety net in healthcare for Americans. Time matters in healthcare, and that at the bedside of a person in trouble, we pull out the three pillars: the safety net, their vital signs, and performing a primary survey. So this is a real patient. You're working in an acute care clinic and a station wagon drives up. Two men unload an unconscious woman on the pavement and they drive off. And you and your staff run out to find a woman in her early 30s, unconscious with facial abrasions, with slow respirations and a weakly palpable femoral pulse. We can't take a history. That's the history. That's the only information we're going to get. Do we need to worry about her spine being potentially broken? Yes, we do, because we don't know anything about her, and externally she has evidence of facial trauma. So we're going to get all of our staff to log roller, to put her on a backboard such as this. The whole idea behind a backboard is we can strap her to it, and we now have control over her airway. So if she starts to vomit, we can tilt her, and she won't roll off of it, and her spine's in a neutral position. We're going to do a jaw thrust maneuver. So we need to keep her spine in a neutral position. She would be on the backboard. Sorry, guys. Jaw thrust is just get that tongue out of the way. The tongue is the leading cause of airway obstruction. But you notice if I have to do this jaw thrust, I can't do anything else. So we have some basic tools, which are simple airways to allow us to get access, to keep that tongue out of the way. And that's what we're talking about when we talk about an OP airway, is an oral pharyngeal airway. And then we're going to start to bag her. We're going to start to oxygenate her by bagging her to get extra oxygen into her and get the CO2 out. And because she has no airway protection, we're going to place an endotracheal tube. We're going to go ahead and intubate her and then make sure that tube's in the right spot and confirm its placement. Her blood pressure's low. She's a victim of trauma. Her blood pressure's low. Perhaps she's bleeding internally. We're going to get those IVs, and we're going to start to hang that crystalloid, that normal saline or lactated ringers. Now we're at the D part of our primary survey. So A, we've got spine's immobilized. We're breathing for her. She's on oxygen. We're pouring in fluids. We're sending off labs. We're at the D part. She's comatose. Her pupils are small. She's not responsive at all. What things do I do now, given her altered mental status? It's the don't. You're supposed to do the DON'T regimen. So what do? Yeah, we do a finger stick glucose, and if it's less than 60, we give her dextrose. Oxygen, we'll look up at the monitor and make sure that's okay. Naloxone, by all means, let's give her naloxone. For all we know, and she was a heroin overdose from the field who had rollen down an embankment after she'd overdosed. And that actually stabilized her vital signs but didn't help her wake up, and we go ahead and give her thiamine. And then E is exposed, getting her undressed, covered with warm blankets. And now, you see what we've done? we've done as a group, so to speak, there's just not time to act it all out. We've taken an unstable patient who's critically ill. She now has an airway. She now has her spine protected. She's now well oxygenated. She now has all her labs sent off. We're now resuscitating her with volume. We've identified already that she's a heroin overdose because she responded to naloxone. And now we can move on and carefully evaluate her, because what we've done is we've purchased time on her behalf. And that's what it's about. The final thing is just quality CPR. Guys, the new guidelines came out in December, and even if you're frightened to do mouth-to-mouth resuscitation on somebody, if you see somebody go down, remember your heel of your hand is between their nipples, on their sternum, your arm is right over, keep your arm locked, and we're going to compress 1.5 to 2 inches just like a machine, and our rate is 100 per minute for patients aged 8 and over. And we do 30 compressions, which I'm going to lose count, about 30 compressions, and then two breaths of ventilation, and then back to chest compressions. And in the setting of Seattle, where our response times are so quick, if you say, that mouth-to-mouth stuff scares me, that's okay. Just to do chest compressions in the first minutes of a resuscitation is life-saving for our patients. All right, I'm over. Okay, thank you. Thank you.